Well, let's get started. It's 8:35. I'm Randy Wong. Thank you very much for joining our live webinar Q&A about the treatment for floaters. We're doing this monthly as of January 2017, and I think it's pretty helpful, if for nothing else, that you have the opportunity to ask your own questions and I can answer them in real time. I didn't really change the title, What is Vitrectomy? But tonight we're going to talk about really a posterior vitreous detachment, and we will go over the agenda in just a few seconds. Now, I just want to make sure everyone can see this slide, which is What is Vitrectomy June webinar. Chrissy, I know you're there. Just type in that you can see it, and then I know we're okay. Or Nader. So I'm Randy Wong. I'm a retina specialist. I'm an ophthalmologist. I'm located in Fairfax, Virginia, which is just outside of Washington, D.C. You may be here because you visit our websites, or one of my websites, either vitrectomyforfloaters.com or retinaeyedoctor.com. I need to go through the disclaimer and state several things. That number one, this webinar is for informational purposes only, whether you see it live or on YouTube. This webinar does not offer medical advice, so nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may quickly become, outdated, especially due to the nature of the topics covered, which are constantly evolving. The materials and the information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or retinaeyedoctor.com or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, you are not creating a doctor-patient relationship. Although I am a doctor, I am not necessarily your doctor until and unless there is a written agreement specifically providing for a doctor-patient relationship. Okay, we've got that done. What I want to do tonight is have a very short presentation. We're going to talk about the aspects of how important a posterior vitreous detachment is with regard to having a vitrectomy. So we're going to define what is a PVD, or posterior vitreous detachment. We're going to talk about the advantages of a PVD with regard to a floaters only vitrectomy or a vitrectomy. We're going to go over a video, or I'll show a new video that I've posted, and then we'll open it up to questions and answers. Hopefully we can do this in 30 minutes. So let's move on. So the first thing I want to do is define a PVD. PVD stands for posterior vitreous detachment. A posterior vitreous detachment is a natural event, and that means it happens to everybody. By the time we're 70 or 80 years old, both of your eyes will probably have undergone or sustained a PVD. So it happens to everybody. The most common signs or symptoms of a PVD are flashes and floaters. And the real question, or the real medical concern about the new flashes and floaters is there a retinal tear that may cause a retinal detachment? So this is a natural phenomenon which can lead to retinal detachment. And that's important because we're going to, in certain circumstances, induce a PVD. So we're kind of accelerating nature in a way, but without really increasing significant risk. The question in this context is, in those that sustain a posterior vitreous detachment who notice floaters, do they remain? You've all seen this illustration before. And what I did tonight, which is different, is I put in the red arrows to show that the red arrows are the posterior or the back half of the vitreous, whereas above or towards the top of the illustration is the anterior part of the vitreous. So that the posterior part is the back half of the eye compared to the front half of the eye. Now, some of the advantages of a PVD when you're considering to do vitrectomy are the following. Chrissy just told me that I'm still on the first slide. Does that change anything? Huh. All right, let's try it again. Sorry about this. All right, Chrissy, what slide are we on now? All right, I'm going to go back.
Can you hear me? Randy?
Yeah.
Yeah, we were on the advantages slide. Now we're on the Q&A.
What are you on now?
Just your name and stats, like your retina specialist, where you are.
Okay.
Disclaimer.
And is that all you see?
No, now it's what is PVD. It's the slide.
How about now?
Still, what is PVD?
All right. So just to repeat, posterior vitreous detachment is a naturally occurring event. The usual symptoms of a posterior vitreous detachment include flashes and floaters. Those aren't, sometimes they can be completely asymptomatic, but for the reason for our discussion tonight, a lot of times patients that have had a PVD have residual floaters. The real medical question is whether or not there's a retinal tear. Sometimes after a PVD, the floaters may or may not persist. Chrissy, did the slide just change?
Still on the same one.
Hello? Chrissy?
Nope. Can you hear me?
Yeah.
Yeah, still on the same one.
What do you see now?
Still the same one. What is posterior vitreous detachment?
How about now?
Same thing.
Sorry, everybody.
Okay, we're good now. Now it's another one.
What do you see now?
Just
Posterior
the image.
vitreous. Okay.
Yep.
So this is an image of a posterior vitreous detachment. I've added the arrows showing in red that what the posterior vitreous is and how it moves forward. So when there is a PVD with relation to a vitrectomy or FOV, there are certain advantages. It allows me to more efficiently remove the vitreous because the vitreous is more mobile. It allows me to remove more vitreous because it's a more efficient situation, because the vitreous actually is able to move towards my instruments as I'm removing the vitreous. And what this obviates is the need to operate very close to the retina. Chrissy, can you see a black screen now?
I can.
Hello? All right, so I'm going to attempt to show you a video. This is a recent vitrectomy. It has a gigantic floater, but also a PVD, so you may be able to see it. Can you hear the audio? So this is a patient who's basically got one eye and has had floaters for about 4 to 5 years. And what you can really see in this video is the dense shadows or the large shadows that this gigantic floater is casting on her retina. And it's really no wonder why she can't see. That blue arrow just showed the optic nerve. You can see the normal retinal blood vessels. But what's really significant is this enormous opacity, which gives her this gigantic shadow on her retina. And I think most of this is pretty much intuitive. She has a large floater, which really blurs her vision, and it's extremely distracting, and she's been putting up with it for 4 to 5 years. So as you watch, I'm doing the vitrectomy, and I'm trying to preserve or trying to demonstrate how the vitreous actually comes towards my instrument, and that I'm not going toward, I don't need to go to the surface of the retina. And this is the beauty of having or operating in a patient with a PVD, whether we have to induce it or it has already naturally occurred. So to note is that there is this large spidery type floater. The retina is actually completely normal. There's the macula. And you can see as we as we start to remove this opacity, the amount of shadows on her macula decrease. And we would expect this to correlate or translate to much better vision. And in just a minute, I think almost everything's going to be removed, happily. I'm also going around trying to shave or remove most of the peripheral retina. I'm also inspecting the retina under direct visualization, and everything seems normal. This is a very, very healthy eye. And you can see now the huge difference in that there are basically, I don't see any shadows at this point related to the gigantic opacity that might be obscuring our vision. So this is a great example of a large floater, but with a posterior vitreous detachment. And I think what's significant is that you never see my instruments need to get near the retina because she's had a PVD. the vitreous will actually come to the instrument. And here's all my accolades and my thanks. We did this at Woodburn Surgical Center, which is in Northern Virginia. And I just put this up on YouTube so you can see it again. We put this on a couple days ago. Here's one of my 2 websites. And then when you listen to the video live, we got some great music, which I used with permission from Brooklyn Duo. What I'd like to do now is open this up to Q&A and use the chat function in your window to go ahead and ask questions. I'll read the questions and then answer them as best I can. Come on, you guys, don't be shy. No one has any questions, or no one can see how to open the chat. Different issues. Hold on one second. Apparently there are questions I can't see them. Is that right, Chrissy? Oh, here we go. Sorry about this. All right. User error, my fault. Dr. Nader Moinfar says, what distinguishes me? Well, you're a great surgeon. You're a great friend. So somehow I missed a lot of this, and that's just my fault. I apologize. Okay, so Rob wants to know how many vitrectomies I've done. I actually don't know. I've been in practice for about 26 years. I'd say somewhere between 10 to 20,000. I think it's a lot. I'm sure there are many people that have done more, but even many more that have done fewer. Vitrectomies, as you point out, can be done for many reasons. In this forum, it's for only patients with floaters, but the actual core operation is exactly the same, whether you do it for macular hole, retinal detachment, epiretinal membrane, etc. Neha asked, do you remove the vitreous near the cornea? There's actually no vitreous at all near the cornea. The vitreous gets as close to the natural barrier between the vitreous and the cornea is the lens or the iris. Rob wants to know, what were the bad outcomes so far? Well, I've had one where I think the young man, for some reason, pushed on his eye incessantly the night after the operation. In 26 years, I've had another bad outcome, perhaps due to infection, but we don't know, in a patient who had severe proliferative or severe diabetic retinopathy. It's just hard to know exactly what the causes are. You know, when you're talking about retinal diseases, there's a lot of retinal diseases where the disease actually wins. So what I'm kind of glumping together is that you've got all these bad diseases, and sometimes or many times the disease wins. With regard to opacities or floaters, I would say a significant, probably greater than 95, 99% patients improve dramatically. Neil asks, is there any risk to getting one done? Well, there are significant risks, but the chances of those significant risks happening are quite small. Or I should say, there are dramatic risks which could happen, and the chances are quite small. Most ophthalmologists fear blinding infection inside the eye. With vitrectomy, the chance of that at most is about 1 chance in 10,000. And if you compare that to cataract surgery, the chance of that happening is about 1 in 2,000. I think there's probably a 1 to 2 to 3% chance that a retinal tear could occur, depending on your situation, and that may lead to a retinal detachment. Those are the two things that I'm concerned with most. Cataracts, I think, are kind of overstated. I don't think that's a necessary complication because they're so easily dealt with. Nader says, how does visual acuity play into your decision to do surgery? Well, I personally don't consider visual acuity because I think the biggest question is how much or how do these opacities interfere with the patient's vision? And that we don't have any way to measure that. And I am satisfied with, as long as I'm convinced that whatever patients are complaining about move to and fro with eye movement, ergo it's got to be in the vitreous. And as long as they accept the risks, I'm willing to embark on the discussion about what do we do with it. Rob asked, what is the percentage of the cataracts? I'm 53 minus 9 with contacts and minus 925 with glasses. I'm told my retina is thin. I'm worried about tears. I think that the chance of tears in a minus 9 is mildly overstated. You're not minus 20. I'm not sure that your explanation that your retina is thin is truly accurate. I don't think that someone who is minus 5 or minus 1 versus minus 9 has a true disadvantage or should have any additional worries. If you were minus 20, I think you might have some real concerns, but I think someone at minus 9 is not a significant concern to me. Nader asks, will insurance pay for this? As far as I'm aware, and Chrissy may back me up on this, I don't deal with any of the insurance issues, but I'm not aware that any insurance does not pay for this. So what I'm saying is I think that in most cases, if not all, insurance does cover this. Rob asks, if you do get cataracts, when do you need to get cataract surgery? Well, that depends on how intolerant or tolerant you are with the amount of blurriness or change in vision you have. If it's due to cataracts and your surgeon agrees that cataract surgery will help you, then I think that's a discussion you have to need with your cataract surgeon. Mark wants to know that regarding anesthesia, does general anesthesia offer any advantages to recovery? The answer is no in terms of your eye. Having general anesthesia is a little bit more complicated. Your immediate postoperative recovery in the recovery room is probably going to be delayed, meaning you're going to probably be in the hospital or the surgical center a little bit longer. The second question is it safer than local injection? No, because in most cases, you're going to get the local injection in addition to general anesthesia. Can topical anesthesia be used for an FOV? The answer is yes. It's quite possible to consider just topical anesthesia. A lot of retina people don't do that, but there are some that do. And I can tell you at Inova, we are starting to investigate the possibilities of doing a vitrectomy with just topical anesthesia. Rob wants to know, how do I induce PVD? If you look at my YouTube channel, you'll see that I can inject a white powdery substance. It's called Kenalog. It's a steroid, but these particles mix with the vitreous very well, and it really kind of stains or allows me to see the vitreous very well. And then you can see how I separate by suction, elevating the vitreous off the back half of the retina. Mark asks, if hypotony does occur, how is it treated and what are the risks? Well, I'd first want to know what your definition of hypotony is. In most instances, especially with young patients, despite using 25 gauge, I like to use sutures, especially if you're from out of town. I've never had a situation, except for that one young gentleman who pushed on his eye when hypotony was actually an issue. I think that most retina surgeons would agree that if there is evidence of low pressure or hypotony on the first day after the surgery, that it recovers. It's been my experience anyway, that it returns to normal within another 24 hours. So it's not really an issue. Nader asks about the use of lasers for floaters. Is this better? You know, I think there is a growing concern or a growing interest about using YAG laser for obliterating the floaters. And I think it's definitely an option for some people. I don't do it. So I can't say that it's absolutely a good or bad thing. It's not something I choose to perform. I don't think it's useful. I think it is very useful for certain patients. I, as a retina specialist, don't think it's the greatest idea, and you've heard me talk about this before. But there is a growing number of ophthalmologists that do use laser, and it is something to consider. If you're to consider it, you need to ask the same questions that you would ask me. What are the risks? What's the likelihood of me getting better, et cetera, et cetera. I do know that many patients have improved with laser. It's just not something that many retina specialists will endorse. Neha asks, I live in California. Do you recommend anyone in California or Arizona that does this? I don't know anyone in Arizona. I know someone in Newport Beach that might consider this, and at least it'd be a good place for you to start. And I ask you to just email me outside of this so we don't inundate this young man. Do floaters ever come back after a vitrectomy? Well, floaters due to changes in the vitreous generally do not. Floaters can be present because of bleeding in the eye, or inflammation, or a few other causes. And if that's the true nature of the floaters, it is possible that it comes back. One of the reasons I like to, or all of us like to see, as doctors like to see you beforehand, is to determine what's the cause of the floaters. And for this forum, we're talking about floaters that are related to changes in the vitreous, not from blood or not from inflammation. Because in those circumstances, it's possible that the floaters could recur. Jimmy asked, do floaters refract lightning indoors? I think what you're asking is, can floaters cause glare? And the answer is absolutely. Not all floaters do, but it's absolutely possible. Nader asked, if I have a cataract, can you remove that at the same time? Do I use sutures, and can I fly home soon after surgery? That's a really complicated question. Let's take it apart. I don't do cataract surgery, and I generally prefer not to combine cataract surgery with vitrectomy for whatever reason. It just adds another level of complications. It's standard that the cataract surgery takes place separately from the vitrectomy. The question of do I use sutures, I think I answered before, is I commonly do it, especially in young people, and especially if you're from out of town, even though I'm using 25 gauge vitrectomy. I don't use 27 gauge yet. It hasn't really become the mainstay of our institution. And as far as the operation is concerned, you've heard me say many times before that I'm not so sure it adds that much to the operation. Can I fly home soon after surgery? And the answer is yes, as long as gas is not utilized. There are a lot of surgeons that use gas afterwards for a straightforward vitrectomy. Gas, in my opinion, should only be used for retinal detachments and macular holes. Maybe another instance that I can't think of right now, but for a floater only vitrectomy, there's no need for gas. So flying home the next day is quite likely. Neil asks, any complications? We got LASIK about 3 years ago with doing the surgery now. No. Any problem with any past surgery with your cornea, any corneal disease shouldn't have any bearing on to your candidacy for having a vitrectomy. Chrissy wants me to add that most do actually fly home after surgery, usually Saturday or Sunday, after having surgery on Friday. Rob wants to know, if I get a tear, do I fix the tear? I look for tears at the end of the operation. Any tears that I see, we will absolutely fix. Nader asks, do we need medical clearance? Absolutely. You need medical clearance for any surgery, at least in the state of Virginia, which is where I operate. So you will need medical clearance. Chrissy can help you with that, as well as Ashley. Neha asks, what is frill and how common is it? Frill is something that I didn't understand until several years ago, and I believe it to be the situation where patients can see where the vitreous was removed. It's a boundary where the vitreous was removed, and they can see the edge of where the vitreous remains. It occurs more often in young people than older, and is something that has made me change the way I operate to inducing a PVD, because it has decreased the incidence of frill. Nader wants to know how far out I'm booked for surgery. Well, happily, most retina surgeons should never, ever be booked, because we always have to account for emergencies. But for what we're dealing with tonight, we're not ever really booked. Probably if you call now, or if we were to see you today magically, we'd certainly be able to accommodate you within the month. Rob wants to know, what is the percentage of people who get cataracts? I don't know. We don't track that specifically. The most concerning to me is young people that get cataracts. And my statement to young people is, it can happen, but it has been our experience that it's unlikely. Hypotony, by definition, which is Rob's second question, is it's just low pressure. It's a concern when we're doing 25 or 27 or 23 gauge vitrectomy, where we don't always use stitches to close the little holes that we make in the eye, and it's possible that fluid leaks out so that the next day the pressure is low. Josh asks, if I have floaters behind my lens, can I get it? Or do you typically leave some behind? I'm going to answer you this way, is that removing most of your vitreous is highly likely to remove the floaters that you see. I have a problem with situations where the floaters are stated to be directly behind the lens. I've never encountered a situation where a vitrectomy has not significantly improved that situation. That's a delicate way for me to answer that. Mark says, how long does the FO procedure take and how much time is actually spent inside the eye? It's our experience where we operate, and I've got a great surgical team. We're probably talking about somewhere in the order of 10 to 20 minutes, 20 minutes when we have to induce a PVD and use sutures to close. So it's not a significant amount of time, but it's not something you should gauge or compare our work to others. Time is not necessarily a great marker when you're talking about surgery. You want doctors that are comfortable with what they're doing, not necessarily doing it the fastest. But to answer your question, we're usually done within 10, 20 minutes. Rob wants to know what the long-term risks are. I'm not aware of long-term risks other than, in the short term, we worry about infection that could blind. We worry about retinal detachment. Cataracts can occur. But after that, I'm not aware of any long-term risks from vitrectomy or FOV. Jake wants to know if the retina has the textile strength of wet tissue paper. Jake, that means you've been listening to me. How does it not tear or detach immediately when you pull or cut the vitreous? Well, and that's the art of the surgery, is that we have technology. It's not me, that we're able to do this in 95% of the time without causing an issue to the retina. It's a very insightful question, but the beauty of the technology with these fast cutting rates and these small instruments, overwhelmingly, most of the time, there's no issues whatsoever. Brian says, given an otherwise healthy eye, what percentage of patients that undergo FOV can expect to have a successful surgery with no complications? I'm just going to say, without tracking stats, probably greater than 99%. We don't necessarily track stats given all the patients that we take care of and for the different situations. And it would be, I hate to say this, it's very difficult to track stats for a particular condition and a particular operation. Josh asks, what is asteroid hyalosis, and if Kenalog looks the same as it will, you use a different dye to see the vitreous? Well, it doesn't really matter. The asteroid hyalosis helps me see the vitreous as well. And using Kenalog, if I need it, will just be an added way I can see the vitreous. A different dye could be used as well. But with regard to your question, it doesn't matter if it's Kenalog or just the natural occurring asteroid hyalosis, which looks the same. In either case, it helps me see more of the vitreous. So in both cases, it's a good thing. Rob says, to be clear, to use general anesthesia. No, in most cases, I do not use general anesthesia because it prolongs the recovery time. There are certain inherent additional risks to general anesthesia. 99% of the time, we use something called local sedation, where you've got an injection around your eye, but you're sedated, etc. Well, Josh wants to know, will FOV increase blue field phenomenon, and have I heard of visual snow? I don't think FOV is related to either one of those. Either one of those can occur outside an FOV. Chrissy wants to add that she wants to make sure that you know that with regard to insurance coverage, most larger PPO-based plans do cover vitrectomy. And if there's any question, email Chrissy directly. That's rwongcm13@gmail.com, and she can figure it out for you. She also wants to point out that Medicare does cover it, as do larger plans like Anthem, PPO, Aetna, etc. Neil wants to know how long is surgery, how long is recovery time, how long should we not use TV, laptops, etc. Surgery is about 10 to 20 minutes, as I just told you. How long is recovery time? You're back to full activity within 24 hours. How long should we not use TV, laptops, etc.? You can use them immediately. Jake says, I have KC of the cornea and I'm -7 in one eye and -16 in the right eye. I'm thinking KC is keratoconus. In the right eye, if I use a special lens, the power changes and I'm -6.5 instead. I know you've said in the past the closer to -20, the greater chance to tearing, but certain lenses require different power, so I'm at a greater risk of tearing. No, in your specific situation, you're -20 because of the shape of your cornea, not the size of your eye. That's a huge, huge distinction. You're -20 because of the shape of your cornea, not because your eye is longer. He also asks, any dry eye outcomes are dangerous to the cornea, as I've heard patients have had some scratches of the cornea. It's not an issue. Even if you were to have a scratch, there shouldn't be any impact to the rest of your eye. Dr. Moinfar says, great webinar, Dr. Wong, very useful. I'll be seeing you soon. Thanks, Nader. I appreciate your support. Josh says, so to clarify, you can't get the floater behind the lens. If mine are 2 millimeters behind the lens, can we get it? What I was trying to say is that there shouldn't be any issues whatsoever. I was trying to politely say to others that make this a distinction. I'm just telling you that as I stated, I don't know of a situation where this has been an issue. I think in your case, if and when you come in, I should examine you. We discuss it specifically for you, but I don't see why that should be a problem. Jimmy says, Dr. Wong, as the vitreous breaks down, would this cause foggy vision indoors under dim lighting? It can. Just as I mentioned before, it can cause glare. It really depends on how thick or large the floaters are. Josh says, is it possible to have this done and then get a cataract 40 to 60 years later? Josh, everybody gets cataracts with or without vitrectomy. So the answer is it's very possible that you'll get a cataract 40 to 60 years after the operation. Neil asks, any thoughts on using daily contact lenses? Dailies total 1 in connection to floaters. No, 0. I think the two are unrelated. Neha says, how long will it take for the redness of the eye to go away after removing a patch? I'm planning to get the vitrectomy done during winter break, which is approximately 1.5 weeks, and need to get back to my rotations immediately after New Year's. I have no issues with you returning back to work or back to your studies. The redness, which is not related to vision, can take as long as 2 to 3 weeks, but it probably does not relate to impaired function. Jake says, thank you very much. Thank you for thanking me. It's been very helpful, and I'll be making an appointment soon. We'll be posting this to YouTube soon. I hope so, but I have to say that I get so lazy or I get so busy that of the 6 or 7 we've had since January 1st, I think I failed to upload 3 of them. But hopefully I get this up very soon. Josh says, I see strobing only at night and pitch black. I think it's the vitreous being pulled on the retina. Can FOV help with this, as it seems to be going on both eyes? All I can say, it's possible. Without examining you, I can't say for sure. Rob says, I see 20/20. I have lived with floaters for over 10 years. I've gotten used to them until this past February. Now they're staying in my optical center in my left eye and also in my right eye, but not as great. This causes constant blurriness and stresses me out. When should I consider getting the procedure? I can't tell you that. I have no idea. There's no set time. You need to advocate for yourself when you think you want to embark on this journey. We don't have a test where it says, aha, it's time for vitrectomy. And I just apologize for that. Jake says, do people still see flashes after, and why is this? Well, patients normally see flashes after I induce a PVD, and that's because the retina is still stimulated. It's not abnormal to see flashes for several weeks or maybe longer. And this is true for patients that have had a PVD occurring naturally as well. Rob says, after the procedure, can I follow up with you in person to make sure everything's okay? Absolutely. If I operated on you, on your doctor, if you live close by or want to stay in the area, I'll take care of you. Josh says, can this induction of PVD cause macular holes? As PVD occurring naturally can cause this. I think I answered you this online recently. We used to think that PVDs were related to macular holes. I think that is an old theory. I've never induced a PVD and caused a macular hole, to my knowledge. Rob asks about follow-up after the first weekend. The answer is absolutely. If you can stay around, I'd love to see you. Josh says, if we induce a PVD and nothing bad happens, do we eliminate any chances of a macular hole? I think I answered that, but the answer is yes, highly likely. Rob says, I live in New Jersey, but I'm willing to come down. I can't wait to meet you. It's not that far away. I'm in Northern Virginia. I look forward to meeting you. This is going to be the last question for tonight, and it's from Rob. Why do all eye doctors say don't do it? They're so adamant. When vitrectomy was introduced to medicine in the early 1980s, it was the first time that we could help patients who had significant eye disease, usually due to diabetic retinopathy. That is to say, up until vitrectomy instruments came along, there was nothing we could do to help these patients. So all of a sudden, there's a new technology to help patients that were underserved. And still, many patients went blind from the disease. Present day, there are still many eye doctors that were in practice in the 1980s that remember that patients had vitrectomy and they still went blind. They didn't understand what was going on. And they didn't understand that they were going blind from the disease. So there is still this stigma that vitrectomy is a bad operation. But when you hear me speak about the complications of vitrectomy, or you read about complications of vitrectomy online and how they're comparable to cataract surgery, is because that the technology has advanced so that the actual complications and fear of vitrectomy should be comparable to cataract surgery, which is the most common surgery performed in the world, meaning one is not worse than the other. All right, one last comment, and I know I already said this, but Neha says, thanks so much for answering our questions. You're welcome. Thank you for attending, Neha. Rob says, thank you so much. You're welcome, Rob. Thank you for attending. I really appreciate your input and your attendance. Jake says, are there any benefits to having vitreous? Once you're born, you don't need the vitreous. The vitreous is there so that things can develop before you're born. But once we're born, the vitreous has no significant function. Neil says, appreciate it. Well, you know what? That's a great way to end tonight. I appreciate your participation and interest in the webinars. I think this is a great way to kind of relate to you and get your questions answered. You know, at some point, maybe there's going to be more doctors that do this. Jake wants to know if I'm going to continue these webinars. Chris and I have committed to doing these monthly, at least through 2017. So the answer is yes. What's my vision for doing these webinars? It helps you potential patients, get your questions answered by someone who does this and someone who is your advocate. So I think there's a true advantage there. And if I am the one that can help you, so be it. Well, I'd like to say goodnight. I'd like to thank everyone for joining. Chrissy, thank you very much for your help in getting this scheduled and moving forward. I look forward to hearing from all of you in the future. And if you feel the timing's right, at some point, call Chrissy, email her, and come on in for an evaluation. Before we go, let me show you how to get in hold of Chrissy. Her email is rwongcm13@gmail. She can help you with insurance, talk about drivers, whether you need it or not, and get you scheduled and getting in to see us. Thanks again, everyone, for joining. I'm Randy Wong. I'm a retina specialist in Northern Virginia. Take care. We'll see you next month. Good night, everybody.